Hello everyone, in this video we are going to learn about version. I am S. Ruth Kesia, working as a tutor in Triple M College of Nursing. Objectives: in this video we are going to learn about the definition of version, types of version, definition of external cephalic version, indication, contraindication, prerequisites, techniques and complications of external cephalic version, definition of internal podalic version, indication, contraindication, prerequisites, techniques and complications of internal podalic version, and role of nurse. So these are the things we are going to learn in this video. First, the definition. What is version? Version is an operation in which the presentation of the fetus is artificially altered, either substituting one pole of the longitudinal fetus to the other or converting an oblique or a transverse lie into a longitudinal lie. So what it says is substituting one pole of the longitudinal fetus means if it is a breech presentation, we can change by as vertex presentation. So like that, substituting one pole with the other, or converting if the lie is longitudinal or transverse. If the lie is oblique or transverse, we can change as longitudinal lie. So that is version. Okay. If the aim of the version is to make the head as the presenting part, then it is called cephalic version. If the bridge will be the presenting part, it is called podalic version. Bridge in the sense the back of the baby, the spine of the fetus. Okay, if the spine is the presenting part, then it is called podalic version. Types of version. According to methods employed, it is referred as external cephalic version, internal podalic version, and bipolar version. First is external cephalic version. Definition: it is a procedure used to convert a transverse lie or oblique lie or breech presentation into cephalic presentation by abdominal manipulation. So this is the definition of external cephalic version. Indication: so in what case we do this ECV is breech presentation or transverse or oblique lie. So the obvious reason is we want to change this presentation as cephalic. Okay, there we want the head to come first through the vagina. So if it is a breech presentation, we can substitute this ECV. If it is a transverse or oblique lie, we can also employ this method ECV in order to bring head as the presenting part. Contraindication. So there are many contraindications for performing this external cephalic version, because we have to keep in mind we are not only altering the baby, okay, the lie of the baby, but we have to come across this umbilical cord, the placenta, the uterus, and everything. Okay, the bone formations of the mother, whether it is a gynecoid pelvis, which is very favorable for female. But if other than the pelvis, which is kind of like android and anthropoid and platypeloid, it's going to be difficult to perform this ECV. So there are many contraindications for performing this procedure. So just to point out, it is multiple pregnancies, antepartum hemorrhage, severe pregnancy induced hypertension, major degree of pelvic contraction, planned cesarean section, scar on the uterus due to previous surgery, RH isoimmunization, preterm labor in current pregnancy, patient is still preterm, elderly primigravida, threatened rupture of uterus, conditions that contraindicate tocolytic agents, gross fetal abnormality. So all these conditions we cannot do the external cephalic version procedure. The prerequisites: the presenting part must not be engaged, because we are going to change the lie of the baby. So if it is engaged, you need to push it above and do it again. Okay, so presenting part should not be engaged, and abdomen wall must be sufficiently thin to allow palpation. If the abdomen wall is very thick, you will not be able to make out which is head and which is breech of the baby. So the abdomen wall must be sufficiently thin, and the abdomen and the uterine wall must not be highly irritable, because it should not, whatever procedure we are doing on the abdomen, palpation and everything, the mother should not go into labor. Okay, and so it should not be highly irritable. The uterus must contain sufficient amount of Leica amni to allow easy movement of the fetus. Okay, so if the Lycaramine is good, sufficient amount only, the fetus will be easily rotated, okay, to perform a somersault. Then only it will be easy. Otherwise, you know, the umbilical cord will get entangled around the head, or it can get anywhere stuck, okay. So the Lycaramine is very important. Gestational age more than 32 weeks, preferably 34 to 36 weeks, and patient is asked to empty the bladder. She is to lie on her back with shoulders slightly raised and the thighs slightly flexed. The abdomen is fully exposed and the FHR is auscultated. Most commonly used medication, that is terbutaline 0.25 milligrams subcutaneous to relax the uterus. So these are the prerequisites for extenocephalic version. Procedure. The breech is mobilized using both hands on the surface of the abdomen, one by fetus head and other by buttocks of the fetus is turned and rolled to the vertex position. Okay, so first is to hold the breech, okay, to mobilize the breech by both hands, and one on the surface of the abdomen by fetus head and the other on the buttocks of the fetus, and it's turned and rolled to the vertex position. Generally, the podalic pole is grasped by right hand. As you see in the picture, the podalic pole is grasped by the right hand and the head is grasped by the left hand till the lie becomes transverse. In step 3, if now the lie is transverse, so we have we have brought the breech from fundus to the transverse position, and now we have to change the hands in order to prevent the crossing of the hands. The hand is now changed one after the other and hold the fetal poles to prevent crossing of the hand. And as in the fourth picture, okay, you can see the head is brought to the lower pole of the uterus. Postoperative management, bed rest is in left lateral position, tocolytic therapy for 2 hours, monitor fetal heart rate every 15 minutes for 2 hours, monitor maternal vital parameters every 15 minutes for 2 hours, watch for bleeding, pervaginum, leaking and abdomen pain. Rh negative non-immunized women must be protected with 100 micrograms of anti-D immunoglobulin. So if the mother, which we are performing ECV, if the mother is Rh negative and she is non-immunized, means she has to be protected with anti-D immunoglobulin. Causes for failure: too big baby, too little amount of Lycaramine, frank breech, obesity, uterine leiomyomas, uterine anomalies, short umbilical cord. So all this can cause failure to perform an ECV. Complications: preterm labor, abruptio placenta, looping of the cord, umbilical cord presentation, intrauterine death, premature rupture of membranes, true knots in cord. So these are life-threatening complications can occur because of ECV. So we don't perform this ECV often in clinical settings. Okay, but you should know what is ECV. So the next type of version is, first we saw the external cephalic version, now it is internal podalic version. Internal podalic version is the conversion of fetal presentation from a transverse or cephalic presentation by both intrauterine manipulation as well as abdominal maneuvers. Indications: second twin in transverse lie, failure of external cephalic version, transverse lie in multipara with the full cervical dilatation, placenta previa with excessive vaginal bleeding, fetus dead or too preterm to survive after the cesarean section. So in all these cases, we can perform internal podalic version to bring the head to the lower pole of the uterus and perform a successful vaginal conduction. And preliminaries: the patient should be in lithotomy position, empty the bladder, general anesthesia is given, and antiseptic cleaning by draping and catheterization are done. Wearing gloves. Gloves wearing is very, very important, because other than the normal gloves which we are wearing till the wrist, in internal podalic version you need to insert your hand still more. So the gloves till elbow is one for the internal podalic version. Okay, so the wearing glove is one separate procedure here. Cervix must be at least 3 by 4 dilated and membranes intact or just ruptured. Uterus should be contracting intermittently with relaxation in between. So these are the preliminaries for internal podalic version. Technique. Instrument drawing. So what we have to prepare is iodine for the part preparation, simple urinary catheter, sterile drapes, sponge holding forceps, version glove. So as I told earlier, there is a separate glove for version, and the episiotomy scissors, instrument for suturing and episiotomy. General anesthesia is given and lithotomy position is given and episiotomy is made, glove are applied and introduce the well lubricated hand. So complete your hand should be lubricated, okay, with the 2% xylocaine into the uterine cavity, and rupture of the membranes should be done if they are intact. Pass the hand on the dorsal aspect of the fetus to its ventral aspect along its breech, and the superior leg is grasped and delivered across the ventral aspect of the fetus. Then the leg is being brought down and the fetal head is manipulated abdominally and shifted to the uterine fundus. So if you see the picture, you will be an immediate breech extraction may be planned soon after the delivery, and uterine cavity is explored for injury. Halothane is discontinued, oxytocin infusion is started. So the procedure, if the podalic pole of the fetus is on the left side of the mother, the right hand is to be introduced and vice versa. Identification of the foot is done by palpation of the heel, while the leg is brought down by a steady traction. The cephalic pole is pushed up and by the external hand. After one leg is brought down, there is no difficulty in delivering the other leg. So as you see in the picture A, the hand is introduced. See the glove they are wearing till mid arm, okay, and the hand is introduced along the ventral side of the fetus to along the breech border, and the superior leg is brought grasped by the hand, and the see they are tilting the baby, okay, superior leg is brought and it is again rotated in order to bring the in order to rotate the baby and bring the fetus leg to the vagina. Once the one leg is delivered, the other leg is not easy. I mean, other leg is very easy to catch hold and deliver the other leg also. So step 5 in routine exploration of the uterine uterovaginal canal to exclude rupture of the uterine uterus and any other injuries. Contraindication: obstructed labor, tonically contracted uterus, and restricted fetal mobility. Complications: maternal risks include placental abruption, rupture of uterus, and fetal risks include asphyxia, cord prolapse, and intracranial hemorrhage. So what is role of nurse in both the procedure? In external cephalic version, check the fetal heart rate before the procedure, pre-medications, fetal heart rate assessment soon after the procedure, every 15 minutes for 2 hours, observe for vaginal bleeding and contraction and leaking. And in case of internal podalic version, you have to arrange for blood. Preparation for general anesthesia, arrange operation theatre, resuscitation of the newborn. Okay, so in internal podalic version, we are bringing the legs to the vaginum and we are performing a breech extraction, and so the theatre setup and newborn resuscitation is everything is necessary. Okay, so that is about the role of nurse in both the procedure. Okay, so till now we have seen about the external cephalic version. What is version? Okay, a version is a procedure in order to change the lie, okay, where it may be a oblique lie or transverse lie, and we are bringing into a longitudinal lie. And if it is a longitudinal lie also, if you want to switch over the poles, like if it is a breech presentation, if you want to bring as a vertex presentation, then you can do it with a longitudinal lie and to substitute the other pole. So that is the definition of version. Okay, so according to the presenting part, this is divided as external cephalic version and the internal podalic version. If the head or breech or is the presenting part, if the baby is in longitudinal lie, then it is called or oblique lie or transverse lie, then we can say we can substitute the external cephalic version. If we have the bridge, that is the fetal spine as presenting part, then we can go for the internal podalic version. And we saw the indication, contraindication, prerequisites, techniques, complication, causes of failure for both the procedures as well as the role of nurse. So I hope you gained some knowledge about version in this video. Thank you. We'll see you again in the next video.